Antibiotic Awareness Week. We just had the valedictory function inaugurated at Thrissur at 7 o'clock. That session is still going on. And a number of branches have conducted a lot of programs, awareness programs for the doctors, for medical students, for nurses, and for public also. Amidst this COVID pandemic, the awareness program was a huge success, considering the number of people benefited by it. Every year, we conduct awareness programs on antibiotic proper resistance, its use, abuse, everything. So, and there has been definitely an impact on the practitioners regarding the antibiotic resistance. This year also, the awareness program must be followed by definite actions from the side of pediatricians and as well as from the side of academy. Certain things we can decide. We can take resolutions. One such thing I just said in Thrissur was that all pediatricians, whether they are in government service or in private service, they should stop prescribing antibiotics over phone. We should prescribe antibiotic only after seeing the patient, after examining the patient. You can very well tell them, see, this is an antibiotic drug. I cannot tell you the name of the drug over phone. You come over here, or if you are staying away, you go to a nearby pediatrician or any other general practitioners and get the prescription. Because after a few years, apart from getting the antibiotics over counters, people themselves will be great prescribers. So to prevent that and to prevent and protect our profession, we should take a resolution during this antibiotic awareness week to stop prescribing antibiotics over phone. Maybe in exceptional situations like COVID, where some containment area or something is there, maybe for a couple of weeks we can do that. But after the COVID pandemic, or even after the severity of the pandemic has subsided, we should all stop prescribing antibiotics over phone. And number two, from the academy side, you all know we have an app, IAP Kerala app. Due to elections, we have not been able to update it and upgrade it, but it will be ready on the 1st of November with a lot of modifications. And in that app, we have included a button for antibiotic awareness. So that button will contain the antibiotics required to treat infections in a particular region. Like if it is Calicut, if you click there, you will get what are the commonest organisms causing urinary tract infection in Calicut, and what are the drugs, antibiotics responding to that organism, and what are the drugs that are resistant drugs to that organisms. So all these details you will be getting. For that, I require the help of the medical college faculty of pediatrics, microbiology, major private hospitals, and major accredited labs. Then only we can have a pool of data which will contain the sensitive organisms and the drugs that can be used safely. So once you see that, all the pediatricians in the Calicut district, so they have a doubt whether this particular UTI will respond to cefixime or should I use ciprofloxacillin. Then once you know that, see, most of the organisms in Calicut are responding to cefixime, so I can confidently use cefixime. I don't have to switch over to ciprofloxacin or any other higher antibiotic. So that will give a lot of confidence to the practitioner. So this app is getting ready. Definitely, it will be coming to your help from the 1st of November. So I want the data, especially Dr. T. Ashraf, Dr. Krishna Mohan, those who are working in the government sector, private sector, everybody should help us by giving data regarding the antibiotic behavior and the behavior of the organism to the antibiotic in your locality. In Kottayam, it will be different. In Ernakulam, it will be different. In Thiruvananthapuram, it will be different. So once you log on to that app, you will know what is the profile of microorganisms in that locality and what is the antibiotics that can be safely used in that locality. So this will definitely there. This is one of our action plan, antibiotic one among the 40 action plans. One is antibiotic awareness program. So this will be there. So I request the help of all of you, all the practitioners and all the members in the teaching faculty to support this app and make it a success. Number 3 is you should have there is during the antibiotic week inauguration program, it was known that there is no data regarding the use of antibiotic prescription among pediatrics in Kerala. All other specialties are having. So some of us should take the initiative to have a data on the prescription behavior of pediatricians, especially regarding antibiotics. So that also we can do. And number 3 is we should have our own audit. There must be self-auditing of antibiotics, that we should audit what all antibiotics you are prescribing. Are we justified in doing that? And in institutions, there must be a provision for peer auditing also. Peer auditing is a concept where you can audit our colleagues, the close friends, and tell them that this is the pattern here, so you can safely, you don't have to take that antibiotic, you can safely prescribe this antibiotic as per the data in the antibiogram of IAP, and as per the latest literature, you can safely prescribe this antibiotic. That is peer auditing. These programs we'll do, and I'm very confident that all these things will work on a long-term basis. The antibiotic awareness week does not stop with 1 week. It has to be there for the coming weeks, not 52, 104, all the weeks it will be there. So this program will be an ongoing program. And I'm confident with your help, we'll be able to run this program. I wish this, I congratulate the Calicut branch for organizing this program, and thank the panelists for consenting to take this program. And thanks to the branch for inviting me, and wish you all an excellent panel discussion led by our friends. Thank you.
Thank you, Dr. Narayanan, for highlighting, for stressing some important points about the antibiotic policy or antibiotic stewardship. Next is by felicitation by Dr. Anandakeshavan, our National Vice President, but I think he's engaged in the Trichur program. He is not in the Zoom platform. So I invite Dr. Balachandra, Secretary, IAP Kerala, for felicitation. Bala,
thank you, sir. Yeah, okay. Thank you, sir. Respected President of IP Kozhikode, Ashraf sir, or State President Narayan sir, Secretary Nihas, Geeta ma'am, Shoma sir, all seniors, Krishna Mohan, Dr. PG, all seniors, IIP Kozhikode. First of all, let me congratulate IIP Kozhikode for organizing various programs on this AMA week. I think this is the 4th or 5th program on Zoom. Just I had to highlight only 3 points. By observing this week, you should do something for the patients as well as for us. First thing is, one is we should have a self-auditing. That is, as you all know, 10 to 15%. We should the OP antibiotic prescription should be around 20-15% only. For that, you should have only self-auditing, and only we'll have an idea how many antibiotics you are prescribing. Second thing is we should display our board on in our consultation rooms about the antimicrobial stewardship and that we are a rational antibiotic prescriber, so that the patients cannot force us to prescribe. And third thing is, after this week, we should reduce at least one prescription a day of antibiotics. That will reduce our disease sale also. So with these words, I once again congratulate IEP Kozhikode and wish this program all success. Thank you. Jai Hind, Jai Hai.
Thank you, Dr. Balachandran. Now, the AMA week awareness theme is handle antibiotics with care. And today we will have a panel discussion. The panel discussion will be moderated by Dr. M.G. Geeta, Professor of Pediatrics, Government Medical College, Calicut. And the topic of discussion is antibiotic stewardship, our responsibility to posterity. I think Dr. Geeta needs no introduction to this audience. So I invite Dr. M.G. Geeta to introduce the panelists as well as to coordinate the discussion. Over to you, Dr. Geeta.
Thank you so much, IAP Kozhikode, Dr. Ashraf, Dr. Nihas, and everyone else for arranging this series of programs regarding antibiotic awareness. And it's indeed a pleasure to moderate this discussion because we have such well-known panelists. We have Dr. Suresh Kumar, who is head of the Department of Pediatrics at Malabar Institute of Medical Sciences. And he has been working in the field for several years and has done a lot of original work in the field. And is very much interested in antibiotic awareness and has a lot of work in IAP as well. And we have Dr. Krishna Mohan, who is the state treasurer. He is again one of the young Turks of the IAP Kozhikode and IAP Kerala. And all of us expect a lot in future from both Dr. Suresh and Dr. Krishna Mohan. And we have Fiji, who's one of the most beloved teachers at Government Medical College, Kozhikode. Students just adore her. And at present, she is doing wonderful work in the PICU with Dr. Jayakrishna. So, shall we start the panel discussion, Ashraf?
Yes, ma'am. Yes, sir.
Okay, Geeta.
Yeah. I just share the screen.
Geeta cost ആണ് ഷെയർ ചെയ്യാൻ പറ്റും.
Okay, okay. Is it visible?
Yeah. Slide show like പോയിക്കോ. Yes.
It is just visible.
Visible.
Oh,
Yes,
okay.
ma'am.
Yeah. So all of us are struggling under the shadow of this COVID-19 pandemic across the globe. And unknown to us, we have also to deal with a silent and more sinister pandemic that has been with us for some time now, which is antibiotic resistance. So unless all of us take steps now itself, sooner rather than later, we'll be in the post-antibiotic era. So that's why we have this panel discussion titled Antibiotic Stewardship, Our Responsibility to Posterity. And I hope our panelists, as well as all who are listening, would enjoy this discussion. First, I'd like to ask Dr. Fiji, there's an organism shown here on the screen, although it really looks more like a ball of wool. Still, this is indeed an organism. What is its importance with regard to antibiotic resistance? Can you tell us? And should we worry much since newer drugs will replace older ones. Do we really need to worry about antibiotic resistance? Dr. Fiji.
Okay. Uh, First of all, I will thank Ashraf sir and Nihas for giving me this opportunity, and also the IAP Kozhikode. Without wasting time, I will directly go to the discussion. So this picture, am I audible, madam?
Yes, loud and clear.
Very
Okay.
clear, Fiji.
Okay. So this is the picture of E. coli, very well known to all of us. But this organism gained much importance in 2016 when a woman with UTI was found to have E. coli having a peculiar gene, the MCR1 gene. MCR means mobilizing colistin resistance 1 gene. So this gene was first identified in USA in 2016, and the importance is that it gives colistin resistance to E. coli. And this is transmissible plasmid mediated resistance by modifying the target where the colistin bind to the organism. So this is a peculiar type of bacterial resistance, and colistin is the last resort antibiotic to multi-drug resistant Enterobacteriaceae, including Pseudomonas, E. coli, Klebsiella, Acinetobacter, and many. So colistin was the last hope for MDR Enterobacteriaceae, but this organism was found for the first time in 2016, and CDC gave alert. But within the next 2-3 years, it has spread to 30 countries all over the 5 continents, and this is a global threat now. So why this happened? Because there is a reason for this MCR1 gene. This was first identified in China. So this can be called a Chinese bacteria even, where colistin was used extensively in the farm, where meat, pig, chicken, aqua farm, and all were treated. All the animal foods were treated with or mixed with colistin for two purposes. One is the prophylactic purpose to prevent infection, and also for the fact that it promotes growth, conversion of food to meat. So this growth promotion was a major reason for using colistin, the last hope antibiotic for human treatment in the farm animals. So in these farm meat, they identified E. coli with MCR1 gene, and that spread to human beings also. That is the picture behind the story behind this picture. And the next question. With that, many countries have banned mixing antibiotics with animal feed, and China banned it in 2015 itself. But in 2016 and 17, 100 metric tons of Chinese food for farm animals were transported to or exported to India for use. So we were using China's product, and recently only in 2019, Government of India also banned mixing of antibiotics in animal feeds. That is the story. And regarding the second question, regarding the newer antibiotics, after 1980, only very few antibiotics have been discovered with all these scientific research. There are few reasons for that. It is very difficult to identify a new class. We can modify the existing antibiotic chemical structure, but a new class to identify it is very difficult. Even if we identify, it should not be toxic. So a lot of trials, years of trials has to be conducted before marketing it, and legal formalities are there. And even if a company do all the research funding and all, with the new antibiotic, they will have to say that don't use it. So this is the only material in the pharmaceutical company where they spend a lot of money in producing, but they also have to say that don't use it or use it very sparingly, and they have to market it at a low cost because this is a life-saving medicine. So with all these, many companies are unable to do all the funding because the return of money will be very less. So only a handful of companies are doing research on antibiotics, Therefore, we are not getting newer antibiotics. So developing resistance to the existing antibiotic is a major threat to to the human beings.
So thank you, Fiji. That was very nicely explained. So as you want us to understand that the rate at which new antibiotics are being discovered is very, very low compared to the rate at which organisms are becoming resistant to antibiotics.
Yeah.
Now I want to, yeah. So I want to ask Dr. Suresh, so is this something that is happening only across the globe in developed countries, or is it a problem for us as well? So which are the common drug-resistant pathogens we commonly encounter in our day-to-day practice? Dr. Suresh?
Thank you, Dr. Geeta. Thank you for your introduction and your question. And thank you, Dr. Ashraf, Nihas, and other IAP office bearers. Of course, it's a very important issue, the resistant pathogens we encounter in day-to-day practice. The resistance means, in one way or other way, all the organisms will have some sort of resistance. There's no doubt about it. And the type of resistance, we can classify it as intrinsic and acquired drug resistance. For example, if you say that it is acquired resistance, intrinsic resistance, a Klebsiella may not be responding to ampicillin if you give. That is an intrinsic resistance. But there are Klebsiella later may become resistant to all antibiotics, including colistin. Now we are seeing even colistin resistant to Klebsiella in practice. So this is how the things develop. And the organisms, if you say the common organisms, of course, the first time when Alexander Fleming discovered penicillin, it was discovered on a Staphylococcus culture media. And he found out that molds, which were actually the fungus which were developing over the culture plate, was showing some clearing in the culture plate around this mold developing. So he found out, that's how he found out antibiotic penicillin. And now we don't use penicillin for staphylococci. So within short time, the antibiotic penicillin, the staphylococci became resistant to antibiotic penicillin. And actually, even though he discovered in 1928, Alexander Fleming was given Nobel Prize in 1945. And in his speech, he actually cautioned the world that we are going to face this antibiotic resistance soon. And we actually didn't give much importance to it. And now we have plenty of antibiotic resistant organisms in our practice, we are seeing, like penicillin resistant Staph aureus, even vancomycin resistant enterococci, and pneumococci resistant to all sorts of antibiotics, ESBL organisms like E. coli and other bacteriaceae, and typhoid. Rias are always used to tell about Dombey-Willy fever and even Contorti fever like that. So the ceftriaxone resistant enteric fever is also now coming up, and MDR Klebsiella is the Acinetobacter resistant organisms. And as Dr. Geeta was also involved in tuberculosis, anti-tuberculosis programs. So she's going to be very well aware of this MDR TB. And now extended drug-resistant tuberculosis is also coming up in a big way. Even in pediatrics, we are now afraid of such severe infections. And even viruses, if you say HIV and influenza, are now getting resistant to antivirals. Protozoa, malaria resistance is there. In Candida fungus, a different type of fungus getting resistance to this. Next slide, please. And you can see that here it is showing the number of infections which are more resistant, like here Streptococcus pneumoniae, MDR TB, and VRIs more resistant, and the infection due to these organisms are supposed to be very common. And that's almost, it's more with the MDR TB infections that are very resistant, a major issue in the public. Now the community is facing problem. Next slide, please. So as we mentioned, already we mentioned that the antibiotics, next slide, please. New antibiotics are actually not being manufactured. Maybe because it is not much work for the companies, and it will not fetch money for the companies. And the other thing is the research will be more and more costly nowadays, not like the initial phase. You have to look for very powerful and very efficient antibiotics for which company has to spend a lot of money. But now the vaccines are fortunately developing, or vaccines are being developed, but antibiotics are not that much. So we are going to face a situation where we will not have much antibiotics to treat high-end resistant organisms. Soon it will happen. And that reminds me of one of the mentors of Alexander Fleming, who said that you should have focused more on vaccine development rather than antibiotics. And that is actually the theory behind, or the thing behind this antibiotic policy. We have to restrict the antibiotics. Unless we restrict the antibiotic use, unless we use it just for clinical clear-cut indications, we are going to face this problem soon. And many things mentioned by Dr. Fiji, also very, very important points. And this is what I have to tell Dr. Geeta. Thank you for that question.
Thank you, Dr. Suresh. So you have pointed out that inappropriate use, overuse are some of the important factors we should guard against to prevent the development of deadly antibiotic resistance. So, Dr. Krishna Mohan, you have been very quiet. What are the important factors favoring the development of antibiotic resistance in our country, especially?
Thank you, Madam. As well as thank you, Ashraf sir and Nihas, for the wonderful opportunity. So, as it has already been mentioned, one important point is the easy availability. It is very easy to get antibiotic in our country. It is available over the counter. We do have rules regarding this antipsychotics and sedatives. It is not easy to fetch them. But from any medical store, if you just go and ask, they will simply give. So that will lead to an increased use as well as an inappropriate use. So I think as an organization, IAP, we can suggest the government to have some regulations to prevent this easy availability of antibiotics. That is one point. Second thing is broad spectrum antibiotics being prescribed as empirical therapy. So for the last 6 months, if we do an audit for the last 6 months alone, we can see that the prescription of antibiotics would have increased. From my limited experience, I can see that from a lot of patients, pediatric patients are prescribed more antibiotics, especially azithromycin, for the last 3-4 months, just because it is COVID and nobody, no doctor or no parent is going to take risk. So what happens is that empirical therapy with broad spectrum antibiotics are taking place. Third thing is self-medication. Self-medication means, especially in the last 6 months, self-medication has increased. The teleconsultation and everything is contributing to this self-medication. And the problem is that the complaints will be poor. They will be starting the medicines by themselves and they will be stopping in between. They won't be taking the full course and everything will be haphazard. That also will lead to this thing. And this infection prevention measures, they are also very important. But due to this, thanks to COVID, for the last few months, the infection prevention measures have improved. I think this hand washing, this cough etiquette, everything has improved. So we need to stress upon that point more. We have to give more importance to that. Another point is global travel. As Dr. Fiji has mentioned about the resistant strains of E. coli. So if it develops in US or UK, in a matter of 12 or 24 hours, it can reach India. So these organisms from one country can reach another country very fast nowadays due to the possibilities of travel. So that is another factor. And another important thing is the lack of proper data regarding antimicrobial resistance. I think Narayan sir already mentioned about that app. That is, every district or every hospital should have a local antibiotic resistance data. That which all antibiotics in this local area, which all antibiotics are having resistance to which organisms, and that details will be available. And I think it has to be done by the medical colleges or the tertiary care centers, and that data has to be shared with the local practitioners also. So I think these are the important points which can lead to the development of antibiotic resistance in our country.
Yeah, thank you, Dr. Krishna Mohan. That was a very extensive explanation of the various factors that are involved. At this junction, I would like to recollect a story that what happened to us last year. We had gone on a trip to Italy, a family trip. And one of our relatives required amoxicillin for a sore throat. Unfortunately, we didn't have it. So we just dropped into a pharmacy and said that, please give us some amoxicillin. So the pharmacist was a very stern looking lady, a very hefty lady, Italian. And she said, where is the prescription? So I said, we don't have a prescription. And then, but I'm a doctor. I can just write a prescription for you. And she said, absolutely, there's no way you can do that. Show me on Google, show me that you are a registered medical practitioner. So somehow we had to go to the Google search engine and show her that I was a medical practitioner. And then she gave us the antibiotic. Then I said, in India, it's so easy to get amoxicillin. And she said, that's absolutely terrible. This should not happen. So, Dr. Suresh, um, you agree with all with what Dr. Krishna Mohan was saying, do you? And can you tell us what is this antibiotic stewardship program?
Thank you, Dr. Geeta. Absolutely right. What Dr. Krishna Mohan said is absolutely right. And Dr. Narayan also mentioned that we should be, is the slide different? I don't know. Anyway, we should be very much clear on the indications when we start writing antibiotics. What we usually do is, we usually take a detailed history, any pediatrician for that matter. We take detailed history, clinical examination, and we decide about the treatment. So what happens is, when we have more patients, we'll be tempted to shortcut everything, and we finally end up with a cocktail of treatment. That's what I also used to do earlier. Even sometimes I I confess that I may be doing it. But anyway, antibiotic stewardship program, antimicrobial stewardship program is actually, we'll actually explain in such a way that, what's a steward? Who look after the passengers in a ship. So I'm a steward. I look after my patients. And I do service to somebody else. Okay. And the stewardship is a job which I am doing. And for antimicrobial stewardship, I'm doing a job in antibiotic prescription. So it's a very responsible obligation. Actually, writing an antibiotic is a very responsible act. That is, our duty is to do a systematic measurement and a coordinated interventions to promote optimal antibiotic use, including choice of antibiotic, dose of antibiotic, route of antibiotic administration, and the duration. Everything should be with clearly measured angle we have to do. That is what the antibiotic stewardship is. So there is a program, there is an antimicrobial stewardship program, which was formally in 2007, the Infectious Disease Society of America, they introduced it, when they intended to monitor and start a proper regimen, selecting a proper regimen of antibiotics, and the duration, dose, everything they recommend. So in 2010, Pediatric Infectious Disease Society, Clinical Setting Research and Education, they were actually, from that time onwards, I think we all were aware that we have to do something to prevent the misuse of antibiotics. So IAP is involved in it. IAP along with ICMR also have formulated protocols to have a proper antibiotic stewardship. So it is our duty that we should have a proper stewardship program exhibited in our clinic, as Dr. Narayanan mentioned. So it is, as Dr. Krishnamohan mentioned, the usage of antibiotic, consumption of antibiotic is very, very high in pediatric population. More than 60% of the child patients receive at least one antibiotic during hospitalization. And more than 90% of children receive antibiotics which are when they're undergoing surgery or other, actually for procedures they're getting, that's the statistics which is shown in the data. So many conditions we are, anyway, we are forced to start, and we have to start antibiotics in many conditions where it is indicated, like a patient with immunodeficiency. Even though we don't have any clear-cut evidence of infection, we might understand that there are situations like that. But we should have a definite criteria to start antibiotics. We should, our aim should be to start on antibiotics with the proper selection of antibiotics and four criteria which are very important when you think about antibiotic stewardship program. One is commitment. Second thing is action for policy and practice. Third is tracking and reporting of antibiotics. Fourth is education and expertise. These are the four very important components of stewardship program. So I think it is our duty as pediatricians to be a role model for our general practitioners and stick on to this program, antibiotic stewardship program, and give guidelines. That's what my opinion is. You can add if you want.
Yeah, you are showing a graph here with organisms isolated in NICU, PICU. So
yeah, okay. Actually,
yeah.
Actually, I didn't explain it much because this is the data which we have the last October, November, December, where the antibiotics. But we, when we start an antibiotic in NICU and PICU or any other area, we should have an antibiogram. Like we should have an idea about which organism is common in, as Dr. Narayana mentioned in Calicut, in our NICU, which organism is common cause of infections. So when we start on antibiotics, we should have this sort of organism pattern in our mind. And same time, like the same, we should have a pattern of antibiotic resistance also in our unit, so that we can decide on antibiotics which we need to give. I just showed this chart that so there was a slide prior to this which we missed. Thank you.
So thank you, Dr. Suresh, for explaining things very clearly. And so now we have realized the importance, the rationale for being good antibiotic stewards and why it is necessary and who is responsible. Actually, you have led us to believe that we play a very important role. Now, through the next couple of scenarios, a few scenarios, which include very common presentations of childhood illnesses, we would like to demonstrate how important it is to prescribe antibiotics rationally. So this is Anu, a 7-year-old girl who has a fever and wheeze of 12 hours duration with purulent nasal discharge and has a history of recurrent nebulization. The question to Dr. Krishna Mohan, who is involved in a lot of work on immunology and asthma, so we have the right person here. Does she really need an antibiotic? And if you are prescribing an antibiotic, will you prefer to do a complete blood count before giving her an antibiotic? Krishna Mohan.
Yes, madam. The question has two parts. Does she need an antibiotic or will you do a CBC? So regarding antibiotic, when we analyze the history, he's a 7-year-old and the symptoms are there only for the last 12 hours, fever and wheeze. And he is also having history of recurrent nebulization for the last 1 year. That itself gives us a clue that he is a HRA, that is a hyperreactive airway disease or asthma. He may or may not be on preventers. So that gives us a clue that he is more prone to develop these respiratory infections. And that is one point. And whether she needs an antibiotic, she's having fever in the first 12 hours, she needs an antibiotic. We can follow this, our state government guidelines. We have the guidelines by DHS of short febrile illness. What they have mentioned is that we can wait for at least 2 to 3 days. They have said 72 hours, but after 2 to 3 days, until and unless the child is presenting with any specific pointers for a serious infection, you can withhold an antibiotic on as well as doing an investigations like CBC. So in this case, at 12 hours, as a practitioner, I won't do a CBC here. And I will wait and watch how she will proceed, and only then I will start an antibiotic. And this simple chart, if we show this to our practitioners as well as the parents, this will help to prevent antibiotic misuse a lot, especially in the respiratory infections. So this is the timeline of a uncomplicated viral URI. So we know that in usual viral URI, it presents with a high-grade fever, and first 2-3 days the fever will be there, and when the fever starts subsiding, the respiratory symptoms starts, cough starts. So this is the point. This third or fourth day will be the usual time when the child may be presenting to practitioners, and the mother will be telling the child is having cough. Then with the typical history, usually viral infection will be having a sick contact, and in this case there is a history of recurrent nebulization, everything is there. With his history, we should be able to tell them that this is the second phase of the viral URA, where the respiratory symptoms are started. So, and this cough, it can, or other respiratory symptoms can last up to 10 to 14 days. In some cases, it can last up to 3 weeks even. So there is no need to start an antibiotic at the first time on seeing the cough itself. So we can withhold this antibiotics. And what are the indications for starting an antibiotic in an upper respiratory infection? So there are mainly 3 indications. If the child is having an acute sinusitis, or if there is an acute ASOM, or if there is an acute pharyngeal tonsillitis, then only we need to start him on antibiotics. So sinusitis, especially after viral URA, so when we have to suspect when the infection is persistent, the cutoff period is 10 days. And or if the symptoms are aggravating after an initial wellness, if the symptoms are aggravating, then also we have to think of sinusitis. Third thing is that severe symptoms as presentation, excessive, high-grade fever, severe headache, cough, etc. at the presentation, that also will give a clue that it can be a complicated viral URA. In all other cases, we can wait and watch. That's all.
So the purulent nasal discharge, greenish, foul
Yes,
smelling,
that
very worried.
Yeah, that color itself is not an indicator for the severity of the infection.
Exactly. Thank you. So we'll go to another very common scenario where again we always are in doubt whether to start an antibiotic or not. So we have a 15-month-old baby admitted with the first episode of seizures and fever. It seems to be a simple febrile seizure. She's been on azithromycin 2 days prior to this, but she's alert, feeds well, but the parents are anxious, and she has polymorphonuclear leukocytosis. At the same time, they refuse a lumbar puncture, and they are happy, or they feel reassured that the baby's mother had febrile seizures at about the same age. So Dr. Fiji, is this a common problem, and will you start antibiotics?
Regarding this, I would like to tell my own experience. I did PG from IMCH. So at that time, in the MBBS period, we were not that much bothered about this meningitis in children. But when we joined for PG, in the first year, the most important knowledge that we gained was in small children with fever and seizure, don't give antibiotics. It will mask meningitis symptoms, and we have seen many cases of partially treated meningitis. So even after 3 years of this PG training, I had always a fear of missing meningitis. So after my PG, I joined in a private hospital where there were a lot of patients getting admitted with the febrile seizure. So all in the initial phases, I also had the same dilemma whether to start antibiotic. Unlike in government medical college, in small or medium setup hospital, private hospital, the parents will not be ready for lumbar puncture. So one option is to give ceftriaxone for 10 days blindly and discharge. Parents will be happy because they have just avoided lumbar puncture. And we won't be able to discharge without completing that 10 days course because we have the fear of missing meningitis, giving a partial treatment for meningitis. But I will thank Dr. Latif sir for giving me the courage. Sir will always say that it is very common, febrile seizure with a very high count is very common, and we can wait. So the points here are: mother had febrile seizure, and this looks like a typical febrile seizure. There is a focus for the fever, that is the URI, and the child has received only azithromycin, which will not cross the blood-brain barrier, and it will not mask a meningitis symptoms even if the patient is having meningitis. Patient will show the symptoms of meningitis in the coming days. And we need not worry about this 18,000 WBC count because and with the neutrophils, because the neutrophils in the body, 90% of them are within the marrow itself. Only 10% is circulating, and of that, only 3% is in the circulating pool, and the rest is marginalized, attached to the endothelium of the blood vessel. Whenever there is a stress, like seizure, severe pain, or vomiting, this marginalized pool of leukocytes will be detached from the endothelium and will enter the circulating or moving blood pool. So the high count soon after a seizure doesn't give much clues to the diagnosis. We need not worry much about this high TC and neutrophilia. We should repeat TC after 24 hours if we have any doubt, and we need not start an antibiotic just because of this TC. That's what I would like to say.
Thanks, Dr. Suki. I think it's amply clear. Dr. Krishnamohan, would you like to add anything to what Dr. Fiji has said?
No, I just want to make a comment. And there is a practice, especially in the peripheral setups, starting azithromycin. In this case also, azithromycin has been started, saying that it won't cross the blood-brain barrier, so it won't affect the diagnosis. What is your comment about that, Fiji?
So here there was no need of starting antibiotic at all. This patient is having a URI only, and if there is no no ASOM, or even if it is ASOM, the first antibiotic will be amoxicillin or amoxicillin clavulanic acid. Azithromycin should not be used left and right for URI, but this practice is increasing because this is an OD dose drug and not having much side effects, and the parents are comfortable with azithromycin. 3 days course may be enough. And so there is a tendency for over prescribing azithromycin for all respiratory infections. That should be discouraged.
So we all agree on this point. Let's ask Dr. Suresh now. This is another scenario. We have a very conscientious pediatrician, Dr. Manoj. He probably attends all IAP meetings, webinars, and all that. He runs a very small clinic and is keen to be ethical, up to date. He sees quite a large number of children, about 1,000 each month, and he wants to know how he can be sure that he is not over prescribing antibiotics. Is there any way we can help him, Dr. Suresh?
Thank you, Dr. Geeta. I just wanted to make a comment on Dr. Fiji's previous this thing.
All right, sure.
What I used to do is in our setting, if it's a very common thing actually, febrile seizures where they come to ED and we do counts, CRP and all. See the count is 22,000, 25,000, and DNB student who is on duty will get panic, and whether we need to do LP. So it's a confusion. If the child is very stable otherwise, we usually don't do LP from there. And sometimes we next day morning, we send the child home. We call them back on 4th day. That was actually after going through a clinical study, a previous one of the papers. We call them back on 4th day. And most of the time, even if we miss a meningitis, 4th day, the child will come with symptoms, and then we can actually show some signs and symptoms of meningitis. That is the abstract of the paper which I got. I actually went through 2 years earlier. Just wanted to mention that rather than starting antibiotics. I think that's a very good practice we can adopt. Then regarding this scenario, Dr. Manoj, actually I represent a population like this. I am a private practitioner. I am actually seeing patients like this in a clinic, actually clinic-like setting, even though in a corporate hospital, in a clinic-like setting. So we see a lot of patients. They come, they sometimes demand for antibiotics. They come and ask us, okay, the first doctor started on azithromycin. Then on first day of fever, they might have gone to a doctor who started on azithromycin. And after the second day, fever didn't subside. They went to another doctor. They started on amoxicillin clavulanic acid, and they expect another antibiotic from me. That's how they come. That's what I usually expect. And till few years back, I used to oblige and I used to start on next antibiotic, that is cefpodoxime. That was the usual practice. So here, the thing is, that was actually over the years, I understood that I was doing a mistake by starting a third generation cephalosporin in a patient who actually do not require even a single antibiotic. So that was an area, as Dr. Krishna Mohan mentioned. We are treating viral infections with multiple antibiotics, no doubt about it. So for a clinician, actually, who, as you mentioned, who is attending all the IAP meetings, all the webinars and all, he will be overloaded with information. We have got ATM module. We have got ARI control program on one side. Then we say we have got conditions like what we can say, persistent bacterial bronchitis, where we almost empirically start on antibiotics. So we'll be confused. So what Dr. Manoj can do, or myself can do, is we should document all our prescriptions, all our patient history, or everything we should document. And we should have actually a measurable data on the number of antibiotics we prescribe. And we should do proper clinical history taking, proper examination, and if needed, proper investigations to come to a proper probable diagnosis that is more closer to the real one, which will tell you whether you need to give antibiotics to this patient. Of course, it is very important that we should understand the patient as a host. Then we should understand the environment and the organism prevalent in that area. Then the resistant pattern, antibiotic dose, duration. These are all always there when we start on antibiotics. And if he is supposed to start antibiotics, he should take an antibiotic timeout. That is, after 48 to 78 hours, he has to call back the patient and reassess whether they actually needed antibiotics. So there is no problem in stopping antibiotics when he feels it is unnecessary. It was given unnecessarily. And we will be giving various combination of antibiotics, and we should try to avoid it other than those antibiotics that are really approved and time tested. And what Dr. Manoj can do is he can stick on to the guidelines, especially all these ARI control program, diarrhea control program, all these program guidelines he can stick to and closely follow up the child. And he can actually look for audit and feedback. He can self-audit, or he can get help of others to audit his prescriptions and his data prescription practice. That is how he can actually improve his practice. If you ask me what I have learned from this, I have been working in this hospital for around 20 years, last 20 years. If you take my antibiotic prescription practice 10 to 15 years back, and now it is very, very different, because 10 years back, I used to prescribe many antibiotics actually. A daily prescription will be, I can say it may be more than 30%, 30 to 40%. But now I hardly prescribe 10% antibiotics in the OP area. And that is how I calculate. I have actually a data of my own regarding the prescription of antibiotics. Now I feel I have improved in writing antibiotics. I'm trying to improve. But it may not be always easy for a practitioner in the sitting in the periphery, as there may be pressures from the patient side, pressure from the peer pressure, and the many pharmaceutical companies will be coming and advertising their products. We are living in a world surrounded by multiple newer antibiotics, different combinations, colorful antibiotic syrups and all. So we are actually forced to write antibiotics. So that is the fact. But we have to audit our prescriptions. We have to stick on to antibiotic stewardship. We have to get feedback, and we have to attend academic programs. I think that is advice I can give to myself. Okay, thank you.
Thanks, Dr. Suresh. I think lots of people would be sort of stimulated to follow your example, isn't it? I really congratulate you for what you have done. You have actually said that we are treating a lot of viral infections with antibiotics, isn't it? Dr. Suresh has mentioned that. So, Dr. Krishna Mohan, is it possible for us to differentiate fever due to viral and bacterial etiology based on clinical features?
Yes, ma'am. To some extent, we can differentiate between viral and bacterial infection based upon the clinical features, but not always. Madam, can you show the slide?
Yeah.
Okay, so this is a slide which I took from the IAP, Central IAP fever module. I will tell this with a disclaimer. This is not a hard and fast rule. There can be overlap between both these things. So usually a viral infection, the presentation will be a high fever at onset, and the child, I already show that chart. There's high fever at onset, and the child will become better by day 3 or 4. And on the other hand, in a bacterial infection, the fever will be moderate onset and peaks on day 3 or 4. And usually, a viral infection, the child will be less toxic compared with a bacterial infection, where the child will be more toxic and sick. And the interfebrile period also, in a bacterial infection, the child will continue to be sick and not normal. So, on the other hand, in viral infection, the interfebrile period, the child can almost be normal. After giving paracetamol, child will start playing again. And another important point is that viral infections usually will be disseminated. That is, more than one systems are involved. For example, in any viral fever, you will be getting this respiratory symptoms, eye symptoms will be there, joint symptoms will be there. On the other hand, in bacterial infection, it will usually be localized to one system or part of one system. And just as we say, something went viral, just like that, in viral infection, there will be a sick contact in the family. So many family members getting infected at the same time simultaneously, we will think more in terms of a viral infection. And bacterial infection, there can be a sick contact, but not always. Next slide, madam. So these are certain things which will give us some clue to think that this is a viral or a bacterial infection. But it need not be always like that. It is not a rule. And regarding pneumonia, which is also very common, it is extremely difficult to distinguish between a pneumonia, especially a sick pneumonia coming to us. We cannot always distinguish clinically. But there can be some clues. For example, the fever, as I already told. And to start with the fever in this bacterial, in this pneumonia, the high fever will be high grade. And the other thing is that when we are seeing the investigations, the X-ray, usually in viral pneumonia, we get a interstitial picture. And bacterial pneumonia, there will be this more of confluent infiltrates, alveolar picture will be there. And pleural involvement also, it is more common in bacterial pneumonias and less in viral pneumonia. And count, when we are looking at the counts, this is also not a strict rule. Usually in a viral pneumonia, it can be a leukopenia, but high counts can also be seen. And usually in bacterial pneumonia, there will be neutrophilia. So these are the some points which will make us think in terms of viral or bacterial. But especially in this pneumonia, we cannot always be 100% sure that it is a viral pneumonia, and we cannot withhold antibiotics, especially if the child is sick. That's it, ma'am.
Thank you, Dr. Krishna Mohan. Actually, I'm not sure whether we are running short of time. Dr. Ranjit, until what time do we have? Dr. Ashraf?
Ma'am, 9:30 is fine, ma'am. 9:30 is fine.
Geeta, continue.
Okay. So what we'll do is we'll go a little quickly through we have 3 or 4 scenarios, and then we have a couple of questions, and then we'll be done. Okay. So Dr. Fiji, can you briefly look at this scenario? This is a 6-year-old boy, 9 days duration of fever, referred with a positive Vidal test. And his sister in Tamil Nadu also has a positive Vidal, the family says. He started on cefotaxime and amikacin and is afebrile after 5 days. And he's being discharged on oral ciprofloxacin because, as per the history, his elder sister recovered with ciprofloxacin. So are we on the right track, Dr. Fiji?
Okay, madam. So for this child, for diagnosing Empiric fever, there may be many pitfalls. And since there is lack of shortage of time, I will just tell the important points alone. Vidal test is if O and H antigen is positive in more than 1 in 160, it can be taken as significant. Below that, it is not so significant. And the first line drug is always a third generation cephalosporin. If the patient is sick, then only we have to give IV antibiotics. Otherwise, cefixime is the drug of choice for enteric fever. 14 days is the duration. If the child is sick, like high fever with vomiting, abdominal distension, not able to take orally, and child is lethargic, we will give ceftriaxone or cefotaxime. There is no need of amikacin. Single drug, third generation cephalosporin is enough. So only that we will need to give cefixime or ceftriaxone. Second line, only if the child is not responding to these drugs, we will give other drugs. Of that, in sensitive salmonella, that means not a multi-drug resistant salmonella, then we can take any of the three choices: chloramphenicol, ampicillin, or cotrimazole. If the patient is sick, we will give these drugs IV or orally. The same drugs, any of the three can be given. And if the child is having MDR and salmonella, azithromycin is the oral drug and estriona is the IV drug of choice. So in nutshell, we need to give cefixime or ceftriaxone. That will be enough. And ciprofloxacin or ofloxacin, these two are the fluoroquinolones allowed, but that is after 18 years only, not below 18 years. Below 18 years, we can use only if the organism is resistant to all other drugs and child is critically ill. That is the thing I would like to say. Next.
Thank you, Fiji.
I have a slide also. The dose we have to remember, cefixime is at a higher dose. Usually it is given 8 mg for usual infection. Here it is 10 to 20 mg per day. Azithromycin also 10 to 20 mg per day. 14 days is the duration.
Yeah. So as you have aptly pointed out, you need to give double the dose than is usual, and you need to give it for a whole course of 14 days, isn't it? That's what you
yeah.
Right. Thank you. Another scenario here, managing children with diarrhea is often a problem, whether to prescribe an antibiotic or not. We are often in doubt. So let's look at this 3-year-old boy who weighs 13 kg, having fever, vomiting, and diarrhea for the last 3 days. He has watery, foul-smelling stools, and stool microscopy shows 5 to 6 pus cells for high power fever. Will you prescribe an antibiotic, and if so, which one? Dr. Suresh, please.
Thank you, Dr. Geeta. This boy, I'll say if this boy is immunocompetent, no basic other immunodeficiency disorders, I will not give antibiotics as it is a watery diarrhea. Even though it is foul smelling, even though the urine stool microscope is showing 5 to 6 pus cells, I will just follow up the child. I will clinically follow up the child. I'll see what is happening to the child. That's the most important thing. Of course, in all diarrhea cases, the most important thing is zinc and ORS. These are the two important things which we prescribe in diarrhea. Probiotics, not all for probiotics as per the current guidelines. And as per the current guidelines, there is no indication for antibiotics in acute watery diarrhea unless you are suspecting cholera, especially if the patient is coming from an area where the cholera is prevalent, or when if you have any evidence of cholera on either fang drop or MMT test or something like that. So, and can it be still bacterial infection? That's another question. The child is having watery diarrhea, foul smelling. Can it be still bacterial infection? Of course, it can be. Even though rotavirus diarrhea and other viral diarrhea are common, it still can be a bacterial infection. But the current guideline, or when we stick on to the guidelines, we should be starting antibiotics when there is visible blood in the stools. That is, your diagnosis is dysentery, unless you are suspecting cholera. These are the indications. Okay, when you start antibiotics in a dysentery also, you should be very careful. because it should be a specific antibiotic, as the resistance is very common against Shigella. Shigella is probably the most important organism where we think about starting antibiotics like ciprofloxacin or something like that. Anyway, stool microscopy has got no role in, no diagnostic role in acute diarrhea, and it will not tell you anything actually. No, it's not a reason for starting antibiotics. That's what I think. Thank you, Dr. Geeta.
Yeah, thanks. It's a very clear message. Now the next question to Dr. Krishna Mohan. This is about a 6-year-old boy who was admitted with fever, headache, and vomiting, with signs of meningeal irritation, with a history of mumps a week ago, and his lumbar puncture shows moderately elevated CSF protein, 20 lymphocytes per high power field, mild hypoglycemia. Would you prescribe antibiotics? And if so, which one? Dr. Krishna Mohan, please.
Yes, yes ma'am. I will see the child, the present level of the child, how sick he is, and then only prescribe. As per the history, he is having a history of mumps 1 week ago. So this is most probably a meningitis caused by this mumps virus following this mumps rather than a bacterial meningitis. So even though in this the CSF study is showing mild hypoglycemia, which is against a viral picture, but in mumps it is an exception. In mumps we can get mild hypoglycemia, and protein also again 50 milligram per deciliter can be a viral picture only. So I will wait until and unless this child is very sick or if it is in very bad. Otherwise, I will wait without starting antibiotics, because most probably this is a case of mumps meningitis.
That's great. So you won't be tempted to start an antibiotic, and you would be sure on clinical grounds that this is most probably aseptic meningitis due to mumps. Isn't it? Fantastic. Now this is another young child, an 18-month-old child with fever, irritability,
Okay.
and a red and bulging eardrum, who was diagnosed as acute suppurative otitis media, put on amoxicillin clavulanate in the right dose. What happened is the child developed diarrhea with the full dose, and the parents reduced the dose to half. And 4 days later, the child has a fit and fever, CSF grows, Haemophilus influenzae. What happened here, Dr. Fiji? Tell us.
So the fact here is with the Haemophilus influenza B vaccination, infections with the Haemophilus influenza B, HIV was usually causing meningitis and septicemia, and non-typeable Haemophilus influenza usually cause upper respiratory infections and even some amount of ASOM. So with this vaccination, non-typeable H influenza have started to cause meningitis and septicemia. And many are having multiple types of resistance. One is due to the beta-lactamase enzyme, and the second is due to the decreased affinity of penicillin binding protein to the antibiotic. So because of that, we need to give a higher dose than usual. And the penetration of antibiotic to the middle ear is less compared to other soft tissues. That is why in the guideline, it is written that 80 to 90 mg per kg is the amoxicillin dose for ASOM. And the same is the dose even if it is amoxicillin clavulanate combination. This is to prevent emergence of resistant strains and causing meningitis. If the patient is allergic to these, azithromycin can be given. But for other respiratory infection, we usually give 45 to 50 mg of amoxicillin, and the parents will be used to that dose. So whenever we write higher dose amoxicillin, the next day parents will have doubt. Even the pharmacy people will tell this is a high dose for this age child. So there is a tendency for the parents to cut short the dose or stop it early. So 7 to 10 days is the course duration. This has to be counseled to the parents at the time of prescription itself.
So you have told us how important communication with parents is, isn't
Yeah.
it? So we really appreciate that. Now, Dr. Suresh, we have all been saying so far how important it is to find out exactly what the infection is, what the suspected organism is, look for cultures, and we choose the narrowest spectrum antibiotic. Are there any situations in which empiric antibiotic therapy is advisable or permitted? Dr. Suresh, please.
Thank you, Dr. Geeta. The question is very clear that what's the role of empiric antibiotic therapy? It is actually an antibiotic therapy or a medical therapy which is which is given when even though we don't have a clear-cut diagnosis, clear-cut indication. We cannot say that we are not very sure that whether it is bacterial or viral infection, whatever it is the condition. But certain evidences will tell you that there is a need for antibiotics. Otherwise, this child is going to have some mortality, morbidity, or some other complication. So it is an intelligent decision to save the life of a child, or save the child, or avoid complications due to a suspected bacterial infection. And the choice should be clear cut. And most of the things we already discussed, what sort of antibiotics we select. So the choosing a optimal antimicrobial regimen is very important. Whatever the condition is, we are starting. The usual guideline for starting empirical antibiotic therapy is like the scenarios which we many times came across in our all national programs is a child coming to our clinic. I'm sitting in a peripheral hospital. The child is brought in a shock-like stage with history of fever. We can say that it can be septic shock, or it can be meningitis. A child with a sick child with convulsions, sensorium is affected. So we say that it can be meningitis. These are all life-threatening conditions. But then we say that we should send the child to another hospital where we can support the child, where a high-end care is possible, tertiary referral center, after giving 1 dose of IV antibiotic. That's the usual recommendation. And they may not be able to even take a culture or any other investigations in that scenario. That is actually a different scenario where it is the main priority is to save the life of a child. But when the child is in our hospital where we have got all facilities, then if you are thinking about empirical antibiotic therapy, we should take investigations like culture and sensitivity from various various body fluids, like it can be blood culture, pus culture, whatever it's available. So that is how the decision is taken. That when the child is coming to our hospital, referred from another hospital, or when the child is coming directly to our hospital very sick, requiring immediate attention, immediate treatment. Otherwise, we are going to lose the child, or the child is going to develop complications. Then we take a culture and other investigations, and we start antibiotics depending on the clinical diagnosis, depending on the prevalence of infection in that particular area, our antibiogram, our sensitivity pattern, and all. And the severity and trajectory of illness is the main deciding factor to choose the antibiotics or decide whether the child needs antibiotics. And the drug resistance is a very important issue. We are mentioning, always discussing drug resistance. So deciding to give antibiotics, we have to think twice or thrice whether actually the child needs antibiotic in such a setting. And of course, the host factor. For example, if the child is an immunosuppressed child, a leukemia child who is on chemotherapy, immunosuppressed, so coming with febrile neutropenia, we cannot wait for culture report or anything. We have to give antibiotics empirically with the particular regimen. But we need not give antibiotics for all other infections like a respiratory infection. So coming with cough, sputum, even yellowish expectoration or greenish expectoration, we need not start antibiotics. It's not an emergency. An empiric antibiotic is not indicated in such situation. So only in situations where we are going to face complications, then only we need to decide about empirical antibiotic. Even if you are starting empirical antibiotic, the dose should be correct, the route should be correct. And if you are starting on IV antibiotics, of course, we should think about changing it to oral. That is always better. And as already mentioned, an antibiotic timeout should be considered. After 48 to 72 hours, we have to readdress antibiotics if we feel that there is no infection and the child is okay. Otherwise, your diagnosis has changed, or culture or other investigations are not showing any evidence of infection, then we can think about even stopping the antibiotics. or the child is improving, we can think about making it oral if you started on IV antibiotics. And these are all pattern of infections. This, as already mentioned, we should have antibiogram for different types of infection. UTI, what is the common organism? And next slide, please. And blood culture, what is the common organism? Pus culture, what is the common organism in that area? And as per the sensitivity pattern, we can think about currently starting probably correct or more close to the correct empirical antibiotic therapy. So the sensitivity pattern also, we should have, each institute should have a sensitivity pattern of the organisms. Thank you.
Thank you, Dr. Suresh. You have emphasized how important it is that each institution should have its own data, isn't it? So, we have all been talking about how important it is to educate patients, but it is a thin line we have to tread. We should not be overburdening them with information. We should not be scaring them with so many facts that they really don't need to know. So, Dr. Krishna Mohan, what should our parents know regarding antibiotics? Dr. Krishna Mohan?
Yes, ma'am. Yes, ma'am. So I think most of the points we have already covered in different parts of this thing. So, ma'am, next slide, please. So, in the patient's language, we have to tell them to observe certain things. First and foremost is that they should complete the full course of antibiotics. There is as we have discussed in one case, there is a common practice that they will stop the antibiotics once the symptoms are better. So that should not be allowed. And there should not be any self-treatment, especially when it comes to antibiotics. It is not like taking paracetamol. So only after prescription from you, we have to emphasize these points with our patients. And we should discourage this doctor shopping. So I can tell you an experience. I am practicing in a place where I am sitting near where Mohandas sir is practicing. So I have many patients come to me, and not now, the pre-COVID era. Nowadays nobody is coming. And the pre-COVID era, many patients used to come, and third or fourth day after seeing Mohandas sir, and they will tell that we are planning to go for a tour. Then I will ask them why you didn't show the. Mohandas sir antibiotic so, so he is very strict in this rational antibiotic policy. And so such patients, being doctors, even though we are practicing, we have to tell them that this is not a good practice. We have to tell them you need not do this doctor shopping. You just have to go back to the same doctor. And you have to tell the patients that never force your doctor, because this is a competitive field. Nowadays we know this is a competitive field, and please do not force the doctor to please prescribe antibiotics. The patients should not tell. And we have to tell them in simple terms that antibiotics are not antivirals, nor they are antipyretics. In many cases, the parents will be telling baby is having high-grade fever, so after the antibiotics start. So we have to tell them that antibiotics are not antipyretics. And we have to emphasize the other infection prevention control measures, hand washing, social distancing, everything. And immunization, we have to stress upon again and again. I'm very sad and unfortunate that nowadays, due to this COVID, recently immunization has decreased. Is decreasing. So as IAP and as being part of IAP and as a pediatrician, we have to take steps to tell the patients. We have to tell them that immunization is very, very important, and rather preventing the infection is more important than treating the infection. And lastly, we have to educate them in their own language, the awareness about antibiotic resistance and why should we need to preserve them. So we can, as Narayan sir mentioned today, we can keep some simple charts or diagrams in front of our clinics. We have to give them the message that antibiotics are precious resources, but they are finite. These finite resources we have to reserve. We have to preserve them at any cost. Also, these simple messages we have to pass on to our patients, so that just like doctors, our patients will also get the culture of rational antibiotic use. That's all.
Thank you, Dr. Krishna Mohan. Dr. Suresh, you want to add anything to this?
I think Dr. Krishna Mohan has discussed it in detail. So I have nothing else to add. Anyway, it is time is going on.
So we are right at the last question. So thanks, Dr. Krishnamohan, for all these practical suggestions. And you have emphasized how important it is to spend time talking to our patients and not just sending them away immediately with a prescription. Yeah. So now we are the very last question, and it's going to Dr. Fiji. How can we all be good antibiotic stewards? Dr. Fiji, the very last question.
Slide. Madam, next slide. So this will be the summary of all the questions we answered in the last 1 hour. So there are many levels where we can observe this antibiotic stewardship. The prescriber already, all the responsibilities already discussed. Accurate diagnosis should be made, local antibiotic guidelines should be followed, and regularly review the need for therapy. The nurse, I would like to stress the point that on discharge, the nurse should be able to counsel all the patients how to take the antibiotic. ബിക്കോസ് ഒരു മില്ലി കൊടുക്കാൻ പറഞ്ഞാൽ ഒരു തുള്ളി കൊടുക്കുന്ന മദേഴ്സ് ആണ് നമ്മുടെ നാട്ടിൽ. ഞാൻ പലപ്പോഴും കണ്ടിട്ടുണ്ട് മില്ലി ഈസ് ഈക്വൽ ടു ഡ്രോപ്പ് ഫോർ മെനി illiterate mothers. So such measurements, how to mix a powder in for making solution, how to take, what is the measurement cup meaning, what is ml, what is half teaspoon, all these should be explained in detail on discharge. Patient should complete the course and should not use leftover antimicrobials for the next illness. There should be an antimicrobial stewardship team in all hospitals to develop guidelines, to do audit and give feedback for the prescribers and educating the prescribers. Next slide, ma'am. The hospital should give funding for these type of educational purposes, and there should be a clinical decision support system, and formulary restrictions should be there. The farmers, the veterinary doctors, all should see that they are not using antimicrobials left and right, even as growth promoters. And the pharmaceutical companies should ensure that they are providing continuous supply of common antimicrobials, and they should limit advertising broad spectrum antimicrobials even among doctors. And the national policy maker can also help by prioritizing and funding such activities and the support use of quality metrics and pay for performance. So all the level, it can work in all the levels, and all should work together to save antibiotics for the next generation.
Thanks, Dr. Fiji. You have very nicely brought out the point that we have multiple stakeholders and all of us need to work in tandem. We need to have a coordinated plan so that we can bring about better awareness regarding antibiotic stewardship. And I would really like to thank our panelists, Dr. Suresh, Dr. Krishnamohan, and Dr. Fiji, who have explained all the points so lucidly. I would also like to thank all the delegates who have attended, all our students and all other senior faculty members, our teachers, and our students as well. And also IAP Kozhikode, Dr. Ashraf, Dr. Nihas, and others, and Dr. Narayanan, who set the ball rolling. Thank you all.
Thank you, Dr. Geeta, Dr. Suresh, Dr. Krishnamohan, and Dr. Fiji for that nicely arranged discussion on the antibiotic stewardship. Actually, there are two questions in the chat box, both of them put by our beloved secretary, Dr. Bala. Bala is there. Bala, you can unmute and ask the question.
Yes, sir.
You are audible, Bala.
Bala, I forgot to thank you. Dr. Bala, I'm so sorry. Thank you so much for joining us.
No, I was there. We should thank you, ma'am, for a wonderful discussion, actually. There's two questions. Is that one is that is there any study on antibiotic use among pediatricians in our state? I think Dr. Suresh has told like that. There is we are using, pediatricians are using more antibiotics. Is there any study?
Dr. Suresh, can you take this question?
Thank you, Dr. Bala. There is no study as such. I could not find any study, but my own data I was analyzing actually. That my patient, my prescription pattern I have actually audited, and it is found that my prescription contained a lot of antibiotics 10 years back, and now the number of antibiotics or the total prescription for antibiotics has come down to from 30% to 10%. That's what my data shows. No other study I could find.
Bala sir, I think from study from GH Ernakulam by Dr. Sivaprasad, I think something related to that. I am not sure. Recently he published one.
Okay. Because in the last talk by Dr. Arvind, he got a statistics of only the adult patients, not the pediatrics from SIT. He did a study in that orthopedicians are giving more antibiotics, more than the physicians. But pediatricians,
I could get adult, I found the adult studies. Actually, surgical specialty is using more antibiotics. Like that. So that's
more than the surgical general surgery, it is the orthopedicians. Yeah. And second question is that Cefixime, madam said 10 to 20. Geeta ma'am, is it there is a fixed dose for that OP patients with typhoid? Should we give 20 Cefixime?
Yeah, we need to give a higher dose. Dr. Fiji, would you like to take this?
20 mg. 20 mg is the dose of Cefixime. In the recent, this is in IAP guidelines.
For endemic fever.
For endemic fever. Azithromycin, it is given 10 to 20.
So there is no doubt regarding the fact that Cefixime has to be given at 20 mg per kg. Thank you, Dr. Bala, for asking these questions and also possibly stimulating members to do some work on antibiotic prescribing in pediatrics, so that probably next year during this antibiotic awareness week, we won't have to say that there are no studies in children. Thank you so much for the suggestion.
Thank you, ma'am.
Thank you once again, Dr. Geeta, Dr. Balachandran, Dr. Krishna Mohan, Dr. Fiji, and Dr. Suresh. I forget to call Dr. Nihas during the inaugural session for the vote of thanks. So now I call upon Dr. Nihas for the vote of thanks.
Thank you, sir.
Thank Ranjit for hosting the meeting.
Yes, okay. Yes, sir. Sir, actually, I put a message to you that no, don't call me for vote of thanks. Now I put the vote of thanks last. So, anyways, it was a nice discussion, Dr. Geeta madam, and well moderated, and the excellent panelists, Dr. Suresh Kumar sir, Dr. Krishna Mohan, Dr. Fiji. Thank you all for that nice discussion. Thank you, Dr. Narayanan, President IAP Kerala, for being here, and Dr. Balachandran D, Secretary IAP Kerala, for being here for most of the programs. And I would like to thank Ranjit for hosting the most of our meetings and being there for all the meetings. I think he's the person who's attended most of IAP Code program, being the host. Thank you, Ranjit, for all the this one. And thank you all who attended today. We had a being an antibiotic topic, whoever takes, it will be like less crowd, but we had something around 80-90 crowd today. Anyways, congratulations to the moderator and the panelists. Thank you all for joining us today. Good night. Thank you.
Thank you. Good night.
Thank you.
Thank you.
Yes,
yes, sir.
October 31st is the last date for our annual report for the state.
Leave
I'll put up in the notice for tomorrow. Today we have decided.
October 31st.
Election October 15. Voting
October 31st.
Voting
election
for the central, because our state conference mostly will be on November 29. So for the judges, there should be at least 2 weeks time.
November program
week last year's report.
നവംബർ പ്രോഗ്രാം
അല്ല, നമ്മുടെ അഡോളസൻ വീക്ക് ഒക്കെ എപ്പോഴാണ്?
അത് കഴിഞ്ഞ വർഷത്തെ ഇതിൽ ആഡ് ചെയ്യണം.
അങ്ങനെ
സെൻട്രൽ ഐപി അയക്കുമ്പോൾ ഈ വർഷത്തെ തന്നെ ആഡ് ചെയ്യണം. സ്റ്റേറ്റിന് അയക്കുമ്പോൾ കഴിഞ്ഞ വർഷത്തെ ആഡ് ചെയ്യണം.
നമ്മൾ കഴിഞ്ഞ വർഷത്തെ വെച്ചിട്ടാണ് നമ്മൾ ചെയ്തിരിക്കുന്നത്. കുറച്ചും കൂടെ ആഡ് ചെയ്യാം സാർ.
ഓക്കെ
സർ, താങ്ക് യു സർ.
ക്ലോസ് ചെയ്ത്